Thank you very much. What we're going to try and do this morning is both Jeff and I are going to talk for about 20 minutes each. I'm going to review growing old, mental decline, the difference between normal aging and dementias, and then Jeff is going to talk about his research efforts. And then at the end of that 40-minute period of time, we're going to leave about 20 minutes for questions and answers. As Jeff and I have talked around the community, we found that more often than not, the question and answer period serves everybody's purposes much better than me talking about my favorite topics and he talking about his favorite topics. We want to talk about what you want to hear about, so we'll try and answer your questions for the last 20 minutes. Today's audience is a little bit different from the audiences that we normally talk to, in the fact that, let's see, I'm going to say 85, 87% of this audience is male, and so we've got to gear it to a male audience. So I brought statistics, and I pulled these out of this month's Journal of the American Geriatric Society, where Alzheimer's disease was featured in their editorial, and just to give you some idea of the scope of what we're talking about. Right now in this country, it's estimated that there are 5 million people with Alzheimer's disease or other dementias, and that by 2050, when I'll be 100, there'll be 16 million people with dementia in this country. Worldwide, right now there's 36 million demented humans on the face of this earth, and by 2050, it's estimated that it will be 115 million people. So you get an idea of the scope of what's happening. Right now, it's the 5th leading cause of death for people over the age of 65. So, you know, if you thought you were coming to this small group and all those guys downstairs with their stents and their prostates and all that, we're the 5th leading cause of death in the country. We take care of it. Just so that for some of you who are caregivers to get an idea of what you're doing, 11 million people in our country today are caring for somebody with Alzheimer's disease, and it's estimated that that comes to about 12.5 billion hours of uncompensated care. Okay, 12.5 billion hours. And there's that, I didn't copy down the figure of how much that's estimated to be worth in this country. And it's also a leading cause of cost, too. As a matter of fact, patients with dementia cost Medicare system somewhere around 3 times as much as people without dementia. And just so you have an idea of where we are on the pecking order, with all those millions and billions, we get right now $423 million in research funds in the country. So, and as you'll hear as Jeff and I talk, right now we don't have any effective drugs for the treatment and prevention of this disease. So what is dementia? What is this thing that we call dementia, and what is Alzheimer's disease, and how does it present? We all get old, hopefully, as General Honore said. That's the goal. And as we get old, there are cognitive things that happen to us in cognitive decline that's normal, and then there's abnormal cognitive decline. So what's normal cognitive decline? Well, I always use the example, you're sitting in church on Sunday tomorrow morning and you look across the congregation and you see a familiar face, but you can't put a name to it. You know you went to school with him for 15 years. You can't put a name to it. And after church, the preacher is finished and you're leaving church and you go over and introduce yourself to this person, and somehow you fake your way through the fact that you can't remember his name, hoping that he'll give you his name. And then you go out to lunch with your wife, and about 2 o'clock, that was George Smith. Okay? Okay, that's, or you know, I get asked in the office all the time, you know, Doc, I'll put my keys down and I can't remember where I put them, and I'll walk around the house for 15 minutes and lo and behold, I'll find them. Or I'll walk into a room and I can't remember why I went in there, and I'll walk back out and I'll walk back to where I was, and I remember where I went in, and I'm going to go back into the room and I do what I wanted to do in that room. So All of those things are normal cognitive decline. Those things happen to all of us. We've all lost our keys and put them down somewhere where we can't remember where we are. We have to hunt around for them. Those things are normal. As we march through, unfortunately, there's not a set point. There's not a chest pain point, if you like, for memory loss, where suddenly it becomes abnormal and we can say this is Alzheimer's disease. So as we march through, we get from normal cognitive decline to what we now call mild cognitive impairment. Mild cognitive impairment is, well, it's more than just I can't remember somebody's name, but now I'm doing a little bit more that's abnormal. I may forget, leave the stove burner on for 5 minutes, but come back and turn it off. Or I may forget to write a check for a month, and I'll make it up the next month, and so forth. But none of it reaches the critical threshold of I can no longer function as a individual getting through the community on a day-to-day basis. And that's mild cognitive impairment. And then that morphs into a dementia. And a dementia is where the degree of cognitive impairment reaches the point where patients are having trouble functioning occupationally or socially in the community. And that's the definition of a dementia. Now, I also get asked the question, well, what's the difference between Alzheimer's disease and dementia? Aren't they all the same thing? No, not really. Okay? Alzheimer's disease or dementia is a pie. Okay? And if you think of a pie, and that's dementia, and if you think of a piece of that pie that's about 70% of the pie, that's Alzheimer's disease. Okay? And then, well, what happens to the other 20%? Well, the other 20% is made up of a number of other conditions that are related to Alzheimer's disease, but aren't Alzheimer's disease. So what are those conditions? Those conditions are Lewy body dementia, which is Lewy bodies are the pathological findings that we see in Parkinson's disease under the microscope. Okay? And Lewy body disease can be Parkinson's disease, can be seen in Parkinson's disease, or it can be a form fruste of Parkinson's disease, where patients have a very distinctive clinical course that's different from Alzheimer's disease, but they look for sometimes very much like Alzheimer's disease. Vascular disease, patients with multiple bilateral strokes can develop a dementia, and that's vascular dementia. There's frontal lobe dementia or frontal lobe dementias that occur, Pick's disease. That's often seen, interestingly, in younger men in their 50s and 60s will frequently present with a frontal lobe dementia. And all of those are forms of dementia. The other 2 to 3% of dementia that we see are what used to be called the reversible dementias. Those are thyroid disease, Addison's disease, B12 deficiencies that are part of the workup for dementia. And what we look for those things because those things we have treatments for that can maybe not reverse what's already happened, but can slow down or stop the progress of the disease if you treat the thyroid disease, if you replace the B12 deficiencies, if you treat the Addison's disease appropriately. So those are the things that make up the pie that is dementia, of which 70% of which are Alzheimer's disease. How do we make the diagnosis? Well, I like to say, because I guess I'm old-fashioned these days, but I like to say the diagnosis of dementias and Alzheimer's disease really gets back to what physicians did 30, 40, 50 years ago before we had modern technology. Because unfortunately today, modern technology doesn't help us very much in making the diagnosis of Alzheimer's disease. So what you got to do to make the diagnosis of Alzheimer's disease is, number one, you got to sit down with the patient and the patient's family members and take a history. take a comprehensive history to find out how this problem has developed. You know, how's it affecting the patient? What's going on? What are the problems that the caregivers are having? And then you do a physical exam, which is the basis of all medicine, and then you order a sort of very simple complex of tests that look for all those other reversible 3% of causes of dementia. And at that time, more often than not, you can reach the diagnosis of Alzheimer's disease or Pick's disease or Lewy body disease or strokes just on the basis of those things. Now, we live in America where we got to do tests, okay? So the other thing that is often done as part of the workup for a dementia is a brain scan. And the brain scan doesn't give us the diagnosis. There's nothing on the brain scan. There's no characteristic gold standard findings on the brain scan that says, or lets the radiologist say, this patient has Alzheimer's disease or this patient has Pick's disease. Okay, why do we do the brain scan? Well, we look for rare causes of dementia, a brain tumor, a subclinical hemorrhage in the brain that may be the cause of the cognitive decline. I can say that in 20 years plus of screening and looking at people and trying to make the diagnosis of dementia, I found one brain tumor in 20 years. I found other brain tumors, but it wasn't because I was looking for dementia. It was because the patient presented with symptoms that suggested they had a brain tumor or had something else going on in their brain other than just a dementia. But in the workup of dementias, I found one brain tumor in 30 years. So in this country, a CT scan is the normal diagnostic study. You don't need an MRI to make the diagnosis, and very honestly, MRI very rarely adds anything over and above what you can find on CT scan as far as the workup of dementia. MRIs are very valuable in other diagnostic arenas, but not for the diagnosis of dementia. A couple words about prevention, and then a couple words about treatment today, as it stands today. Prevention. There was actually this week in the Annals of Internal Medicine, the National Institutes of Health came out with with the consensus conference findings, and basically I'm going to have to tell you, we don't know anything ironclad that will prevent dementia. Okay, we don't know anything ironclad that will prevent dementia. What are the things that we would tell people? What are the things we tell people to do in order to try and prevent dementia? We tell them to have a healthy lifestyle. That is, eat healthy, you know, lots of fruits and vegetables to reduce the oxidative stress that Jeff researches here. We tell them to get their cardiovascular health in line. So after you leave here, go down and listen to Steve Kelly if you really are concerned about dementia, because, you know, make sure you're exercising regularly, make sure your cholesterol and your blood pressure are under control, stop smoking if you're overweight, get your weight down so you don't develop metabolic syndrome and diabetes. So all of those things we believe probably play a role in the development of a dementia, but we don't know that there's a definite preventive force. The other thing I tell my families all the time is stay active in your community, okay? Because we know that if you're socially engaged, if you're working, you're busy, you're going to church, you're staying active in the community, you're going to keep your mental health for a longer period of time than if you become what I call a hermit. And very oftentimes, when I see people with dementia, what's happened is over the past few years, they have become a hermit. Okay? They have isolated themselves from others, family members, and friends. So staying active is also very valuable. Today, the state of the art as far as treatment goes is to Again, make sure that the cholesterol is controlled, make sure that the thyroid is correct, and if you need replacement of B12, we do that. We have approved for use in this country 5 different drugs that have been approved for use of, in Alzheimer's disease. They're not very effective. If they work probably, I think Jeff and I would say our experience is about 30% of the people that we give these drugs to seem to have some mild improvement, where families will come back and say, you know, since you put Dad on this drug, he's more engaged. He can stay attentive to the conversation for a longer period of time than he could beforehand. Is his memory a whole lot better? Does he remember better what he did yesterday than he did prior to the drug? Probably not. Okay? The rest of the people, the other 70%, don't have any improvement at all. And the studies that we have are very short-term studies. They're 6 months in duration, where we take and look at people for 6 months on a drug versus a group of people off of drug for the same 6-month period of time. Drug companies make a lot of claims that go beyond that, and I'm not certain that we know how much benefit we're giving to these patients and families over and above the fact that we're doing something and we're supporting them. And I think that's also very, very important. I think the other crucial factor in caring for patients with Alzheimer's disease is basically taking the time to listen. Taking time to listen to the patient and what's going on with the patient, and taking the time to listen to what's going on with the caregiver. Okay, because as I tell patients all the time, and families all the time, when I see a patient with Alzheimer's disease, I immediately have 2 patients. I have the patient that I'm treating with a drug, if I choose to use the drug, and I also have the caregiver. And I've got to be very attentive to what's going on with the caregiver, because if I lose the caregiver, my patient's going to deteriorate significantly very quickly. So for that, in that respect, I attempt to get all of my patients and families involved with Alzheimer's services here in the city. They do a great job in supporting caregivers, teaching and educating caregivers about the disease. They have lots of resources over there on North Boulevard at Steele, and they're an integral part of caring for someone with the dementia. And I think at this point in time, I'm going to stop, because I've just about used 19 minutes, and Jeff and I are going to take a minute to swipe mics, and then he's going to talk about what he does.
Well, it's nice to see a lot of new faces. I've been in Louisiana for 2.5 years and given countless talks, and it seems I have a lot of the same faces, and I'm definitely seeing a lot of new faces here. I had one thought as I pulled up here today, and that is that I hope to have to do 2 things today. One is to have everyone in this room leave a little more informed than when they walk through the door on Alzheimer's and normal aging. The second thing is I hope to make this a much more pleasant and fun experience than the 100 people out there getting a prostate exam in Louisiana. So that's the bar I've set for myself on this right here. So with that intro, so we started, I came here 2.5 years ago, and we started work on developing this thing that we call the Institute for Dementia Research and Prevention. And part of me moving here from Kentucky was that in Kentucky I was the assistant director at one of the 29 Alzheimer's disease centers that are in the United States, NIH-funded ones. And I just thought every place in the country was like Lexington, Kentucky, and that everyone understood what Alzheimer's disease was. Everyone knew where to go for the treatment. There was nobody falling through the cracks. It was just a fine-net system that was in place for Alzheimer's disease research as well as Alzheimer's disease quality of care. And when we were being recruited down here, it became very obvious that there was a huge gap in Louisiana with regards to Alzheimer's work. And so what I tried to do when I came here was to set up exactly what we had at the University of Kentucky, and we've been very successful at that, and I'll explain a little bit more and how you might want to become involved. So what I'm going to do now is talk a little bit about Alzheimer's disease, what we know from research, both at national level as well as what we're doing here locally. So the first thing that you need to know is that Alzheimer's disease, when I always get asked the question, is Alzheimer's disease an inherited disease? Is it something that's familial, genetic? Well, that's a little bit of a difficult question to answer. So the first thing that you need to know is that these forms that are clearly genetic, the people that do inherit this disease from one of 4 different genes that we know can cause Alzheimer's disease, that occurs in about 5 to 8% of people with the disease. And it's a very different disease than what you see in the sporadic, or in other words, non-genetic forms of the disease. And that is that these people usually develop the disease before the age of 65. Almost all of them do. They develop the disease at a much faster rate. And the pathology that you see in the brain is a little more severe than you would see in a typical sporadic case. So you would say then, usually we say that 5 to 8% of people have a genetic form of Alzheimer's disease. But it's not that simple. So we know that things like Dr. Gahan was mentioning earlier, things like diabetes, hypertension, these things also contribute. We don't have it defined yet, as Pat alluded to, but we do know that these things in midlife do seem to contribute to the development of dementia in later life. And of course, these things can be clearly inherited. So whenever you say, is it does inheritance or genetics play a significant role in Alzheimer's? I think it plays a pretty major role through these other risk factors, if you include those in there. We have families here in Louisiana that, for example, the Bourgeois family, they're in our study. That's a family where 11 out of 13 siblings had Alzheimer's disease. So, and what's very interesting, they're in our research program, and one of the things that you realize is that that family also has an extremely high incidence of hypertension. Okay, so it's, are these two things just related, or are they causal? Are these things working together? And that's one of the things that we're trying to work on here at the Pennington. The second thing is the biggest risk factor for Alzheimer's disease is aging. So 1 in 7 over the age of 65, 1 in 2 over the age of 85. That's what statistics are given on that. Although those numbers probably really underestimate the incidence. It's very hard to get an accurate number for how many people do have Alzheimer's disease, and part of that has to do with just simply it's underdiagnosed. That's one of the things. The second thing is that we don't understand, with insurance companies and other things, one of the problems is oftentimes the insurance companies will want people to code this as something called organic mental disorder. And it's very hard to, things like diabetes are very easy. It's very easy to pull medical records and figure out how many people have diabetes in a given population. Whenever you're starting to categorize things like Alzheimer's as organic mental disorder, that becomes more difficult. So things are starting to change, but we would say that at least 1 in 7 over the age of 65, 1 in 2 over the age of 85 have Alzheimer's disease. But the thing you need to know is those numbers, it's not an inevitable aspect of aging. So it never goes to 100%. So in Kentucky, we were lucky enough to have about 19 centenarians. So these are people that live to be 100 years of age or older. And in that group, we had largely a dementia-free population. Now, please don't leave here saying that Dr. Keller said that in Kentucky there are 19 people over the age of 100 that act just like and have memory just like a teenager. That's not what I'm saying. It's adjusted for age, but these are people that have dementia-free lives. So the other thing that you need to know is that in studying these people, we're trying to figure out why is it these people live to be 100 and remain dementia-free, whereas other people, 1 in 2 over 85 have dementia. How can we explain this? And I've got some very bad news. So what we found out, and this is why you do research. My mom always says, It's so obvious. Why do you have to do a study on this? We all know it causes this, or we all, it's so obvious. And I always say it was also very obvious that the world was flat until that was disproven too. So, we have to do the research. But the idea is whenever you look at the diet, the lifestyle, and everything else of these people that live to be 100, there's one thing that emerges, and that is, I'll give you one. All 19 of those centenarians still smoked. So, they're a very hedonistic lifestyle of these people. And what we walk away from that as scientists learning is that what that means is that there are very small amount of the population that no matter how stupid and hedonistic they are, they're going to live to be 100. Okay? For the rest of us schmucks, we've got to do everything we can to maximize our ability to get there. Okay? So these people were born blessed and took advantage of it, and the rest of us have to work at it. And one of the things that you need to know is that research is really important. So it's really confusing, something like obesity. So does obesity contribute to the development of Alzheimer's disease? Well, one of the problems is, half the studies say yes, half the studies say no. Well, the problem is you're comparing apples to oranges. So people aren't looking at how, for example, obesity is not a big problem, or is much less of a problem in people over the age of 70 as compared to people age 40 years of age, particularly here in Louisiana. So if we look at, is someone obese now? Do they have dementia now? That's a very different question than saying this person was obese at one point in their life, this person wasn't. Does it influence the rate of dementia later in life? Those are the kinds of, they're more difficult to ask, but that's what we need to do, and that's what we're doing here at the Pennington. The second thing is that things like diabetes. One of the problems is that you just simply can't know everything. So I went to school for over 20 years, and I still don't know everything that I need to know. And you simply can't bring everything that you need to bear on that question. So people that are neuropathologists and neuroscientists, when they do their studies, they just simply have a questionnaire that asks, do you have diabetes? And you know what? Diabetes is dramatically underreported. And a lot of people in this room have diabetes and don't know it, or pre-diabetic and don't know it. The second thing is that it doesn't take into account the severity of the diabetes in the person, the degree, how well it was treated, all of those sorts of things. And so science is slowly catching up on those things, but that's one of the big problems in doing research is you really need to design your studies to ask the right kinds of questions. Exercise is another one. So neuroscientists spend a lot of time designing the experiment so that we measure the cognitive performance and all of that the right way. And then we have an exercise intervention that's kind of willy-nilly. So we got people here at the Pennington who do world-class exercise research, and now we're matching them with people that do world-class dementia research to understand, does exercise influence the rate of dementia, both incidence as well as progression of the disease. So let's see. The other thing I wanted to allude to was that, yes, in the news, one of the big things that's come out is this use of imaging and such. A lot of imaging is used in research side of studying dementias, maybe even more so and put more importance on it than in the clinical setting. And you get these newspaper articles reporting what these different scientific studies show. And one of the things is that those things are very misleading. So I don't know if you know this or not, but you can't believe everything you read. I don't know if you... Hopefully you'll leave here, Dr. Keller said that you can't believe everything you read. And one of the things is, the latest one, as an example, they show that that this imaging technology was 100%. And if you look in the Alzheimer's cases, they 100% blindly could find which people had Alzheimer's disease. Okay? They predicted it with 100% accuracy. The newspapers and everything pick up on that, and it's new diagnostic test for Alzheimer's disease, detection earlier and earlier, greater and everything. The next line was that it also detected Alzheimer's disease in 40% of normal people. Okay? Let's ignore that. Let's focus on this. So the problem is, if I come in and I tell you, you need to be screened, we've got something that will detect Alzheimer's disease, and it has a 40% chance of picking it up in people that are normal individuals, we've got a problem. Okay? Got a big problem. And that's there's such a need, such a demand on this, that the cart goes before the horse. Okay? Oftentimes the cart's pushed down the hill, down the road, and everything else, and the horse is still up there. And it's because of the importance of this topic. But that's just one example. The other is diet. So diet has actually yielded some pretty high impact papers now. Things coming out in the Journal of the American Medical Association. What we're doing is neuroscientists, again, are sort of catching up with doing diet stuff right. And what they're finding is some very unique things about how dietary combinations do seem to influence the development of these things that Dr. Gahan was talking about, MCI, mild cognitive impairment, as well as Alzheimer's disease. We're also doing work in that area. And the other thing that I want to say is that if any of these topics are of interest to you, in November 2nd, we're having our Alzheimer's Town Hall Symposia here at the Pennington in the evening. And what I've done is, because our research is moving towards physical activity, exercise, diet, and how they regulate the rate of brain aging as well as dementia, I'm bringing in a couple of world experts to come in and talk about their work on this. And so you'll be hearing about what we're doing as well as what these world experts are also finding in their groups. So if that's of interest to you, November 2nd at 5:30, and you can go to the Institute for Dementia website. If you type in Institute for Dementia Research and Prevention, or IDRP, we're the second thing that pops up there. So if you Google that. All right. So let me talk a little bit, because we are going to open it up to questions. So I'm going to tell a little bit more about what we do so that you understand that a little better, and then Pat and I will be here for answering questions. Okay, so we have two studies right now. So the first one is called Louisiana Aging Brain Study. So we call it LaBrains. You got to have a cute name, or scientists don't like to quote it. So we're called LaBrains. What that is that's people age 60 and over. I think we have a few in the room. I'm looking around. I'm not sure. I think I see one or two. And what we do is we have people come in and we give a comprehensive baseline. So they get a very good measure of their cognitive performance. So it's not just memory. So it's things like executive function, things like attention. We also do a depression inventory on people. We take detailed information on physical activity, all this health history. What we're going to do is we're going to follow people over time. What Pat alluded to earlier was that our test right now, I firmly believe that the detection of dementia in the earliest stages, moving to earlier and earlier and earlier detection, is not going to come from a magnet and not going to come from pictures, but is going to actually come from better ways to measure performance. So one of the problems is that, again, I don't know if y'all know this or not, but there's a wide range in what's considered normal cognitive performance. Okay? There's a wide range. So, you know, I'm an active, I fish every week, and these dumb shrimpers that are down in Thibodeau, you know, that I see, those guys can do anything. Those guys, to me, are like the smartest people in the world, and people, you know, up in New York City are saying that they're not the brightest people. But how do we capture that? You know, one of the problems is so many of our tests are based on education-based sorts of things. And so one of the things we're doing is we're working on better and better tests for measuring these sorts of things. And one of them is, for example, this what Pat alluded to earlier was facial anomia. That's the #1 complaint people have, is that I see them and I should know them, but I don't know, and sometimes it comes back to me and sometimes it doesn't, and I don't, you know. So what is normal with this facial anomia? Well, we actually have tests for that. We're giving it to thousands of people around Louisiana. And what we're finding is we're establishing what is normal facial recognition. So if I show you a face, does it come to you? Do you know who it is? Maybe instead of knowing the name of the person, you know why they're famous. Okay, that also tells us as neuroscientists something. If you don't know the name, but you know the context of that person, that tells us something about the brain areas that are working. The second thing is, if I tell you their first name, like for example, if I show you a picture of Ronald Reagan, and you say, he was an actor, he was president, he was, you know, and you're going on, and you can't do it, and then I say Ron, and you say Ronald Reagan, that also tells us something. If I can prompt you and the recall happens, that tells us something. So we're always developing these new tests to understand what is normal aging as well as what is abnormal aging. And the biggest thing I want you to leave here knowing is that it's so important. You know, out here, people, that's what a lot of these people out here are doing, are getting baseline measures. There's actually a pretty broad range in what's a normal prostate, for example. So there's large, that we know it's too large, but it's not everybody has one size here, and if it's any deviation from that, then it's abnormal. There's a range. And so one of the things you need to do is, in a few years, I firmly believe that people will get baseline measures in their 60s on cognitive performance, different aspects. Because if I know how you performed last year, and then I see how you performed this year, I can tell you whether or not you've had a significant change that's much more sensitive than if you just walk in off the street. And so what we do is, right now in our LaBrain study, what we have is we have a study here in Baton Rouge that's about 800 people. We have a study that we just started up in Shreveport that's going to have also about another 800 to 1,000 people. And so we've already established in this 2.5 years here, we got the study that's one of the 10 largest in the world. So probably about number 8. Not that we count numbers, but probably number 8. So we want to get up even higher. We can ask some very powerful questions. And every year we add new things to it, and physical activity measures are going to be one of the big things. Is there a relationship between the number of steps you take a day and the rate at which your cognitive performance changes? What about sitting? We're going to measure how much people sit a day, okay, and understand how that influences. Not only just cognition, but, for example, things like depression. And the other thing that you need to know is that if you want to think about it, every year we turn the crank on this study. People come in every year. It's a free study. And every year that they come in, they get these data, and they help us to understand what causes people to remain stable, what happens to cause people to remain still cognitively normal, but have a significant decline. So they're decliners, but still in that normal range. And then we, of course, have people that will go on to develop dementia. And for those people, we actually have another study. So this is called our Alzheimer's disease study. It's just like the other 29 at these other Alzheimer's centers that are around the country. They all have something called a memories disorders clinic. Well, we have something that's called an Alzheimer's disease study for these people, and Pat Gahan is intimately involved in this. And what we're doing there is that we're developing better measures to understand and measure rates of cognitive decline. How can we better get a handle on understanding and quantifying, has someone gotten worse, or is someone remaining the same, or has someone gotten better? And that's one of the big problems here, is that we don't understand, we don't have the tools that we need. When people develop later stage Alzheimer's disease, those tests that we give them are very ineffective. And we rely, when I test you and see how you perform, that is something called an objective measure. Okay, I know how you perform. If I have to ask someone how you've changed, that's more subjective. And unfortunately, we rely a lot on subjective measures for monitoring disease progression. We got to get away from that, and or maximize that, have more quantitation to that. And that's one of the things we're doing. The second thing is that we're starting to tease apart how diet, activity, and other things influence aspects of the disease. One of the big ones is sundowning. So people that become more confused, agitated in the afternoon and evening hours. Not everyone develops that, but more than 50% do. And so we think that by understanding what are those triggers and ways to prevent those things from happening, we can significantly impact the disease. So we desperately need people who are in the who have Alzheimer's disease in their family to get those people over to our study so that we can start building that research that here in Louisiana that's needed to take us to the next level, and have Louisiana have an Alzheimer's disease center like at the University of Kentucky. The second thing is that we are also actively recruiting clinical trials, so people don't have to go to Birmingham or Houston where these Alzheimer's disease centers are. They can have the latest in Alzheimer's research here at, for example, Baton Rouge, Shreveport. The only way that we're going to be able to convince the industry to allow us to do studies here is when we have a significant number of Alzheimer's patients to work with. And so again, there's a booth out on the second floor over there, right across the hallway. Young lady that Leslie Guillory, who works with us, and she can tell you all about the studies and make it very simple for you to enroll or get more information or pass it on to someone who you think might be interested. Last thing, and then I'll quiet down. Please know, Dr. Gahan also alluded to this thing about 25 to 30% of the people respond favorably to medications for Alzheimer's disease. Okay, what we know is that the rates at which people progress with the disease is very different. The complications of the disease, things like sundowning that I was referring to, are very different. It's a very heterogeneous thing. It's very different. My former mentor was one of the top 10 researchers in AD in the world, and he was famous for saying that the one thing that's consistent with Alzheimer's disease is that it's different in everyone who has it. Okay, he's very famous for saying that. And so what we're finding is that when you look at the pathology, and ultimately we'll have a brain bank here, but whenever you look at the pathology of people who die with probable AD, what we find is that a significant number, very few people die with AD. Very few people die with probable AD, and then, of course, definitive diagnosis requires a pathological workup. When we do that pathological workup, what we find is that very, very, very few people die with pure Alzheimer's disease. In other words, they have just the plaques and tangles. The plaques and tangles are just in the places they're supposed to be. There's no infarcts. There's no frontal atrophy. There's no sclerosis. Very few people have that. What it is that Alzheimer's disease, most people have what we call mixed dementia. So they have the presence of the pathology plus other pathologies. Okay? The other thing is, it's not surprising, 30% of the people that die cognitively intact, people that we knew everything about, followed them for years, whenever they die and their brain was normal, that approximately 30% of those people had AD pathology. Okay? And people like my former boss used to say they just didn't live long enough. Okay? So, we had a person that was 94. We're like, Bill, how old do they have to be? So the bottom line here is that what we're going to see is that the words Alzheimer's disease are going to change. We're going to be talking more about syndromes. And so the reason why that's important is that it's not just some bald guy from Kentucky trying to play words and stuff. It's very important, because what will end up happening is that people with Alzheimer's syndrome type 1, primarily someone that develops Alzheimer's disease with just a little bit of vascular abnormalities, those people may be 100% responsive to the current medications. Okay? Whereas people with Alzheimer's syndrome type 2, who have more of a frontal atrophy and a certain amount of infarcts in their brain, we know will not be responsive to these medications. So it'll guide how disease is treated. The other thing that's going to happen is it's going to actually develop the drugs. If you want, I'm going too long, but I just need to do one more minute here. So if you want to think about it, it's where cancer research was in the 1950s. So in the 1950s, people had cancer. So it wasn't that people had liver cancer, prostate cancer, lung cancer. It was people had cancer. Okay? Cancer was treated like, if you had cancer, it was treated pretty generally. It was studied. It didn't matter which cell line you used. It didn't matter what tissue you used. Cancer was cancer. Well, we all know that's asinine. And we've seen the improvement in both the detection and treatment and management of cancer and survival rates. Same thing's going to happen here with Alzheimer's disease. We're going to be talking about syndromes. We're going to be talking about better understanding of what causes what. And then when we do our experiments, when we do our trials, we're going to find that we have people that are tested not for Alzheimer's disease, but for Alzheimer's syndrome type 1, 2, 3. And that's how we're going to develop our therapies. If we just keep treating it Alzheimer's as Alzheimer's, you're going to have the same problems you did in treating cancer as cancer, okay? So it's the same sort of deal, and that's on the horizon, and it only comes through research, and I'll shut up and allow people to ask questions. So thank you for your time.